Hello, my wonderful classmates. I'm sorry I can't be there to give you this presentation. This is the case study of BS, a 78-year-old female who came to us short of breath with chest pain. As it would happen, we discovered that her daughter called 911 because she had been not acting herself, so we'll call it altered mental status, for several days. And she'd also been fatigued and weak, not herself, feeling a loss of appetite. Um, she also had epigastric pain for months, and the daughter felt that this was associated with today's crisis. So rather than go to Methodist, where they usually go for treatment, they came to OSF because they wanted to find out what's really going on with mom. So the chest pain and shortness of breath onset was on the ambulance ride. And when we asked Methodist for records on the epigastric pain, we discovered that this patient actually has a history of a hiatal hernia. Methodist did an EGD, and they discovered, if you don't remember, a hiatal hernia is when the stomach pushes up through the diaphragm. So where there's a sphincter at the top of the stomach, and it should be supported by the diaphragm, now it's pushed up over top of the diaphragm, and it ends up kind of pushing that sphincter open because of the pressure below it, and that allows acid to escape. So what we think happened in this case was she got tipped back, repositioned by the EMS crew, and that allowed a splash of acid to come up her esophagus. So that caused her chest pain and her shortness of breath. And by the time they had given her aspirin and 3 nitros, the acid had kind of settled back down into her stomach and the burning had stopped. So she said, "Yes, you relieved my chest pain. We think that that's what happened." She had a recent history of a UTI. The daughter believed that this was cleared up. There was no known history of acute coronary syndrome. Take a look at these vitals. We love seeing a high blood pressure because that means the patient is not going into shock. So in the emergency department, this is fine, as long as it's not a hypertensive crisis. If I were passing this patient over to you, I would also mention, of course, the patient is a full code. She's going on a renal diet because as she's being admitted, her GFR is a 28. Since she's usually treated at Methodist, we don't know how her GFR trends over time, but today it's a 28, so today she's getting a renal diet. Her daughter has her glasses, and her history of problems includes Alzheimer's, which is why her daughter is answering all questions for her. Not only does she have Alzheimer's, but today she's confused on top of that. She's got a history as a smoker, diabetes type 2 with neuropathy and CKD, hypertension, hyperlipidemia, and Hashimoto's hypothyroidism. Please forgive me for my voice. So medically, here are the possible problems that we're running through in order of life-threatening priority. And in the middle here are the labs and tests generally associated with the things you see on the left. I can tell you the thyroid came back normal. The blood glucose levels stayed within the range of 100 to 200 during her whole stay with us. That is consistent with her A1C, which is 8.1. That means on average she has a blood glucose of about 185 when she's at home. It didn't do anything different for us. With sepsis, we would expect hyperglycemia, so we would have expected to see it shoot way over her normal. It didn't do that, so again, she ends up with sepsis. But the doctor called it sepsis without acute organ dysfunction, which to me sounded funny because I thought sepsis had to include acute organ dysfunction. But that's what it says in her chart, so that is what I am presenting to you today. She definitely had bacteremia because we found E. coli cultured in her blood. Of course, this EKG is abnormal because of her potassium and calcium levels. A calcium level of 8.4 and a potassium level of 2.8 is going to give you some abnormalities in your EKG, and that's probably because she had a loss of appetite, and she's in chronic kidney disease stage 3. So her kidneys have trouble reabsorbing electrolytes after filtering them out, and if you're not eating for a couple of days, whew, those are going to fall. She's also got a BUN of 10, so she's dehydrated, and her creatinine's 1.48, so that's elevated. We're worried about her. But that lactic acid is where I think the doctor decided we need to give her a diagnosis of sepsis because of her lactic acid of 1.9. So taking those medical diagnoses and making them into nursing diagnoses, we would say she has a decreased cardiac output as evidenced by her EKG. She's also got, excuse me, inadequate oxygenation and breathing, and you can tell because her lactic acid reveals that some of her cells are doing anaerobic metabolism rather than aerobic metabolism because they can't get enough oxygen to do what they need to do. And we can also say that she has impaired body defense mechanisms because she currently has an infection that started in her bladder, gave her pyelonephritis, and is now filtered out into her blood because the inflamed kidney allowed the E. coli to get across that filtration membrane. The interventions that have an asterisk beside them are the ones that I was actually able to complete myself. So I hung the fluids and the antibiotics. This patient was dehydrated, so she had flat veins, and I did not start the 2 IVs, but I was able to help get the blood draws and the nasal swab too. That was the first nasal swab I think that I had ever done. And it's great that she was able to produce a little bit of urine for the urinalysis. Some SMART goals for this patient would include producing the minimum hourly amount of urine to show that our fluid resuscitation is working. And let's set a goal for 30 mils per hour of urine starting within 2 to 3 hours of when we start resuscitation therapy and lasting throughout her hospital stay. We would like for this patient to remain free of cough, runny nose, other signs and symptoms of respiratory infection throughout admission. She doesn't need pneumonia or something else on top of what she's already dealing with. And it seemed to me that her daughter needed to be educated on UTI prevention since she got a UTI and then it recurred. It seemed like maybe we need to talk about how to wipe front to back every time, or maybe we need to talk about scheduled toileting because this patient has Alzheimer's and it can be hard for her to focus on the fact that she's sitting in wetness or sitting in her stool right now. It can actually slip her mind before she gets somebody's attention, and then she ends up sitting in it for a long time. So maybe we need to talk about scheduled toileting, or the daughter also mentioned that she thought the thermometer was broken because it was reading a hypothermic temperature, and the vitals that I got were also just a little bit below the normal, maybe a degree lower than we would like to see. And hypothermia is actually expected in an elderly patient who has sepsis. So some education about elderly signs of infection, and if you think your thermometer's not working, go get a new one. Don't just guess for several days of your mother acting confused. Not that the daughter is being neglectful. I just think she needed some education. So if I was talking to a new graduate nurse, maybe that new graduate nurse would ask me, what made you think sepsis in this case? I'm looking at this brand new sepsis checklist that tells me when to throw up a sepsis alert at OSF, and this patient doesn't meet the criterion, so what made you think sepsis? And what's the big rush anyway? Like, why do we have this checklist and it has to travel with the patient? This seems a little extra. I will show you the checklist in just a second, but the big rush is that sepsis can lead to sepsis shock, and that would be lethal, easily lethal for this delicate patient with so many comorbidities. So, why did we think sepsis? It really is something that makes me scratch my head the more I research this patient. In general, sepsis means you have an infection, you are of altered mental state, and you have organ dysfunction. In this case, we did see myocardial dysfunction and acute kidney injury, but those things were attributable to other things. The patient had lost appetite. Well, maybe that was because she had the infection, so maybe we should still attribute those things to her infection and call it sepsis. But in this case, I guess the doctor decided because she hasn't been eating, that's why her electrolytes are off, that's why her myocardium is dysfunctioning, and she's getting an acute kidney injury because she's dehydrated, also because she hasn't been eating. So these dysfunctions are attributable to something else, not the sepsis. So we have to say she has sepsis without acute organ dysfunction. It's kind of splitting hairs. I don't care one way or the other, but this patient's lactic acid was up at 1.9, and that should be our big red flag. If a patient has a history of UTI and now they're acting out of sorts, just go ahead and get that lactic acid. So I did a research article. I researched an article that someone else wrote about giving education to staff and rounding on them and giving them a new screening tool to try to get a sepsis bundle to patients quicker. When he started this research, he had staff that was completing the sepsis bundle by about 9.8 hours after the patient had stepped through the doors of the hospital. 9.8 hours. The average time for getting antibiotics to the patient was 3 hours, and under that pre-intervention state, the mortality level was 12.1. Ouch. Compared to 6.2. They achieved this 6.2, again, through education, rounding, asking people, do you have questions about this new screening tool? Do you know that you need to use it with every patient? Do you know what the sepsis bundle is? Do you know what our goals are? The sepsis bundle, by the way, is to get a lactic acid, get blood cultures from 2 sites, and that's part of why we wanted to start 2 IVs, 1 on each arm, so that we're getting blood cultures from 2 different sites on this patient. Then start antibiotics and start IV fluids. And our goal is to get it done within an hour. By the end of this research article, they had completed full bundles on average by 135 minutes, so a little bit over 2 hours. Antibiotics were getting to patients by 84 minutes, a little over 1 hour on average, and the mortality came down to 6.2. I think it speaks for itself. Like, if you hear that the patient has a recent history of an infection, go ahead and start those 2 IVs, get those 2 blood cultures. If it was a respiratory infection, you would be looking for a nasal swab. Of course, you're going to look for a urine sample as well, because the 3 sites that are most likely to produce sepsis are your respiratory system, your blood, or your urinary tract. So those are kind of the 3 things that we focus on. So our benchmark would be about an hour to get these things completed, and we're hoping for about a 6% mortality rate. That's the national average, and that's what we're aiming for. So Barbara's risk factors are she had a history of a UTI, she's in her 70s, she's female, so her urethra is short, she has dementia, so like I said, she can get confused and forget that she's sitting in something that she doesn't want to be sitting in. She's also got chronic disease, so something like diabetes, where her blood glucose is 185 on average, is really helping glucose to multiply and be happy in her bloodstream. So we want to get her blood glucose under control as part of reducing her risk factors. She's got pre-existing organ dysfunction. Her CKD is already a risk factor for her. And we talked about the pathway of E. coli for her already, and how in sepsis the host overreacts to this infection. So if she was truly septic, her vitals would be going shocky because of hyperactive immune response. We didn't quite get there with her because we caught it early, and that is wonderful for her. Some psychosocial things that we want to talk about are finances and education. What does this family need in order to get respite or home health or a helper, if at all? Maybe education will be just the thing that they need to help their mom stay healthy in the long run. And Finally, here are my references.